Pain assessment. So pain is charted every 4 hours. First thing you do when you come in and you assess your patient, you're going to ask them if they have any pain. If your patient is awake, alert, and oriented, by all means ask them and use the numeric scale anywhere between 0 and 10. What's your pain level? However, if your patient is intubated and sedated, we're going to go ahead and use the CPOT scale because they are unable to express their pain level. When it comes to assessment, we have to assess, and if the patient gives you any type of pain level that's not a 0, so if they have mild, moderate, or severe pain, you need to address their pain. You need to give the proper PRN medication that is ordered for this patient in regards to their pain level. If the patient, for example, refuses to take medication, then you have to state some type of intervention that you perform to help the patient with their pain. Let it be readjusting them, repositioning, helping them get out of bed to chair, whatever the case may be. But you have to address their pain. Not only do you address it, you then have to reassess their pain level within 1 hour of that patient telling you that they were in some type of pain. Very important, guys. You have to assess your patient, and if they have any type of pain, address the pain and then reassess within the hour. Once you reassess, you're going to go ahead and document your reassessment. So your documentation has to reflect those 3 things. Again, it has to reflect your assessment, your intervention, and your reassessment. To chart your pain, you're going to go to your main menu, click on pain assessment, and as you can see here, you pick either assessment or reassessment depending on which one you're doing, which scale you're using, numeric rating. You choose the number that the patient states they have pain. If it's a 0, nothing else needs to be done. If you're using the CPOT scale, you're going to put unable to self-report, and it will automatically ask you if you want to use the CPOT scale. And you just go ahead and answer appropriately. The facial expressions, your body movement, muscle tension, things of that nature. If the patient is on a ventilator, you'll go ahead and respond yes. Whenever it comes to documentation, you just want to make sure you complete it as fully as possible. PRN medications. I just want to take a moment to make sure to convey that it is extremely important to pick the appropriate pain medication ordered to the corresponding level of pain your patient states they have. I know a lot of the times things happen as in the patient will tell you, oh, what works for me is this. Well, depending on the actual pain level that they give you is what you have an order for. So you can't work outside your scope of practice. So if the patient says that they have moderate pain, that they have, let's say, a 5 out of 10, that is in the moderate pain scale, you as a nurse only have an order to give, for example, here, tramadol for this moderate pain. You cannot automatically jump to the fentanyl, which is only ordered for severe pain. So I want you to make sure that you understand that 0 equals no pain, 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 10 is severe pain. All pain medications in your MAR will have some type of indication of what it is actually for. Here, tramadol's for moderate and fentanyl's for severe. Sometimes you'll see for breakthrough or for even mild pain.
Pain is a very big deal. Of course, we want to do whatever we can to ensure that our patients are as comfortable as possible. We want to use non-pharmacological as well as pharmacological interventions. It's very difficult for an intubated patient getting suctioned, hooked up to lines and monitoring devices. Hard to imagine that they're actually comfortable, so please keep that in mind and never get frustrated with the patient that has difficulty settling. Narcotic administration and pain management are both highly regulated and monitored by CMS and the Board of Nursing. Assessment of pain must be documented immediately before we administer narcotics, and then reassessed within an hour. There's two reasons that this is important. One is to make sure that we're addressing the pain and that the interventions we are using are appropriate. The second is to ensure that the patient is not having any adverse reaction to the narcotic. Primarily hypotension, respiratory depression are things that we see with narcotic administration. As mentioned, there are a few things that we need to watch out for. One is called therapeutic duplication. This is when we have two drugs that are ordered for the same level of pain or anything else for that matter. And again, the drug that you choose to give must match the level of pain that you're documenting. So even if it's the other way around, the patient is reporting severe pain and you only have an order for moderate pain, technically you're not allowed to give that drug. We had an RCA not so long ago where the nurse gave morphine for severe pain without an order. Luckily, she documented that she gave the medication and was simultaneously paging the doctor for further orders, but it was ruled that she was practicing outside the scope of nursing because the order she had was 2 milligrams of morphine for moderate pain. So another important thing to know is that because many of our patients are on IV drips to control their pain, the rate that you run the drip must always match the level of pain that you are documenting. So if you go up on the rate of the drip, there must be documentation that the pain level also went up. Also pertaining to IV drip medications, you need to be very careful that you are not exceeding the parameters that are stated in the orders. For example, the order may say 2 to 5 milligrams morphine per hour. You cannot be running it at 6 milligrams per hour. You need to have the provider change the order and be careful because a nurse-provider communication does not suffice in this case. Also, the order will actually state how fast you can increase or decrease the drip. You need to be aware of the order and you need to adhere to the order, or you need to get the provider again to change the order. There are quite a few very important things to remember about pain assessment, reassessment, narcotic administration. Please make sure that you learn how to properly document narcotic waste. I would recommend getting familiar with Anywhere RN. It's a program designed to allow us to waste at the bedside and make drug administration easier. So please get familiar with that program.
Sedation assessment is only assessed if your patient is under sedation. So if your patient's awake, alert, and oriented, you could go ahead and skip this part. So you'll find sedation assessment in your main menu. We use the RASS scale, and you would pick the appropriate level of sedation. If the patient's lightly sedated, if the patient is combative, whatever the case may be.
So just like analgesia, the sedation orders have parameters dictating the rate and the rate in which you can increase or decrease the drug. So RASS documentation must match the parameter in the order. If you have to go up on your sedation, then you need to be able to document an increased RASS at that particular time. Again, weaning the sedation must be done in accordance with the parameters stated in the order. You want to be particularly careful of this when you're doing sedation vacation. So you'll be decreasing or restarting sedation, and you want to make sure that the RASS that you document reflects the changes that you're making. Another thing that you might want to know, if you don't already, is that fentanyl, although analgesia, is also considered a sedative. So we will be documenting RASS whenever we are using a fentanyl drip. So in conclusion, I'd just like to point out that there is a field in the sedation assessment that is used to record the BIS value. BIS is a bispectral index, and it's a number that reflects the depth of sedation used when we paralyze and sedate our patients. At this point, we won't say much about it other than just for you to note that it's in this section.